tensor imaging, fractional anisotropy. Now I know, unless you're doing DTI here, this is something that, so the answer is a very good question, because addiction does not come in one flavor. It comes in many flavors, like cancer. Many different forms of cancer. We call it cancer, but we know that there are many different, some very treatable, some lethal. Addiction, and this is what's helped us in understanding the biology, is that the individual who gets addicted from pain medicine has a different, as far as we can measure now, I would love to continue these studies here with you so we get a much larger N clinical samples, but that the biology of how the brain deals with it. And the fascinating area is it is almost exclusively related to dopamine, which is fairly rare. Usually we have norepinephrine, serotonin, GABA, but dopamine seems to be a really critical part of differentiating those. And what we've seen is the greater the genetic loading, the more likely it is to develop it with pain. So why this is important is we can very likely, in the very near future, and would love to study this with my dear friend Professor Samir here, is that if we can identify a group of children or adolescents who we know are at greater genetic risk, and we just tell them, maybe don't use opioids, use other, amphetamine, non-opioid treatments, because there is a difference, and in fact, in the treatment response, there's also a difference. So as we learn more about the biology of addiction, we will become better clinicians. And then I believe another important issue is the family supports. We talk about, patients who have a stronger family support system tend to do better in treatment, and we can measure that in the brain as well. We can measure how mesolimbic dopamine and white matter tracks, and we have this change in diffusing tensor imaging, which I have many slides on that, but they would be boring. So it's a very good question. We need to study them more, but the answer is yes, we think that is absolutely the case.
Welcome, Dr. David in Cairo.
Thank you.
Actually, I went to Los Angeles in 2010, and I stayed there for 5 months in ISAP. With Dr. Rick Rawson, Larissa Moni, and others, but unfortunately with me, however, I feel familiar with you too much. I have a comment here, which I know about tramadol in Egypt. The use of tramadol is for decreasing fatigue.
For fatigue.
They use it particularly among young adults who are ambitious and they wanted to work for 12 hours, 18 hours, and so they use it they feel safe about it, they can take a half a tap or whatever, but actually he usually goes in the trap of addiction as usual. The second, I want to ask your opinion about legislation of cannabis or marijuana in Los Angeles or elsewhere. What do you think about why? And if you have the decision in your hand, would you like to do or not?
Well, I can answer both of those, but thank you for in the US, amphetamines tend to be used more for a stimulant. A student wants to stay up all night to study, or they want to stay up all night to party. That the amphetamines are used as energy producers, not so. But thank you for that, because that helps me understand it a bit more. The story of marijuana is a very simple answer for me. The government did it for tax dollars. It was a financial. There is no data to show that it hasn't had a negative effect. The only people where it has a positive effect are the people running the marijuana sales, because they're making lots of money, and the government who's taxing it. In the adolescent world, we've seen a spike in first episode, psychotic illnesses. So if you look at the literature, if you look at the data, there is no argument. The only minor argument they make is, well, if you're selling it legally, then it's pure. In other words, it doesn't have other bad things in it. This was the issue with with MAT, which we saw on the tape, the use of methadone, which I know is not permitted here in Egypt. Methadone is just as addictive, is just as negative as heroin, but it's pure, and you're getting it from the methadone clinic. So it's not a treatment, it's a substitution treatment, but you can control, so allow someone to get other forms of treatment. So I think any physician, any addictionologist, any child psychiatrist in the United States who follows this literature will say the same thing. This is not a good thing for health. But there are political reasons. And as we all know, money talks. Well, listen, I don't want to take any lovely questions. I'm really looking forward to hopefully we can work together on training and developing that next level of experts with clinical experience so that we can address this problem to help all of our patients and educate all of our students and trainees. Again, thank you very much. We look forward to working together, inshallah.
Thank you very much. You had, I think, a lot of questions, and I think if we say we can have more, you will have more. Now it's the most difficult thing. How should I introduce my colleague? We have been together for 33 years, the three of us, Mahat, Samir, and myself. 33 years together, wow. I think this is the longest thing I have ever done in my life, for 33 years. I asked Samir, how should I introduce him? And he said, handball player. So there is a nostalgia there. But Samir has always been interested in both training as well as in addiction and general psychiatry. And what he's presenting today is addiction medicine unit activities. So, can we have?
Thank you, Professor Saad. Thank you, Professor Maha, for the last 33 years. Last 7 years. And I know all the time that I'm older than you and Saad by 20 years. I don't know how. But thank you for accepting me with you. And I've learned a lot from you. You are heading by me by many steps. As you know, at that time, when we started the residency, I was a handball player. I was not indulged in the faculty of medicine or the residency years after I stopped playing handball. And you always taught me a lot in psychotherapy and how to have a sheet with the patients and how to tolerate patients. And I said, okay, thank you, but I'm going to the training now. And thank you for your wisdom and good advice that I've taken from you along that year. And thank you, Dave, for coming here and spending all that hours of flight and presenting your honorable lecture to us. Professor Mustafa told me to present this, the work activities of our department. And the one who had the honor to present it is Professor Maha, who is the head of the department. And if we did some activities since we opened the hospital since 2007, I think there's a lot who helped us in the addiction unit, like Mumtaz Abdul Jawad, Professor Mumtaz Abdul Wahab, and Professor Tariq Abdul Jawad, and a lot of the residents who helped us to initiate this. Actually, in the slide الأولاني, I'll talk about educational activities, therapeutic activities, research activities, training, and projects that we are involved in, and cooperation with other areas of interest. In our addiction medicine unit that runs the activities in the units, we take care of 30 patients. Our unit have 30 patients. Some of them are, they get inside for free, and some they pay for it. And along with those patients and some master degrees and MD degrees, we run multiple activities. The first education activities is the teaching the addiction curriculum to the 6th year of the medical school, the teaching of the prevention and early detection of substance use disorder to the house officers in Kasr Ainy hospital. We teach lectures to the psychiatric residents. As you know, they are moving between the child psychiatry and the adult psychiatry and the drug addiction. We introduce the conference every week, 3 weekly case presentations with Professor Muhammad, Professor Abdul Rahman, and the colleagues with the effort of Rania. The practical case taking, the practical peer supervision, the group and the individual psychotherapy that's done in our unit. Of course, the teaching to the master degree and degree candidates, the teaching psychiatry to the undergraduate psychologists, and we have an eminent psychologist in our department in training and in actual practice. We have a good outpatient activity. We have 4 addiction clinics per week. 100, we see 120 patients per week. We adjusted 30 patients per day to give a good service. We usually do the assessment by the psychiatric resident, psychologist, and senior lecturer. He's present in the clinic each time. We apply the matrix program, 3 groups a week, 40 to 60 patients we see a week at the outpatient level. Urine screening before, it is an obligatory before we see them, to avoid mixing of someone who relapsed or having even relapsed with others who are still in control and sober. Individual psychotherapy, the family group psychotherapy, I think Dr. Rani is doing it once a week. The psychoeducation program, denial breaking to the families, to break all the defenses done by the families to see the sons and daughters are okay. Sometimes we prescribe medications to them if they pass through depressive episodes. Next, please. The therapeutic activities among the 30 beds, as I've mentioned, we see a pure substance use disorder patients, usually polysubstance abuse. We see cases of psychosis and mania. We refer them to the psychotic department for a while till being controlled out of the psychosis, and then they admitted to the program of the addiction unit. The detoxification measures, of course, motivational interviewing skills, the motivational incentives, 4 group therapists per week, and of course the Department of Psychology is giving us a good help every time. The daily morning organizational meeting to read papers, to talk about the emotions, any dreams, any craving activities or craving thinking to destroy it in the early beginning of the day. The reflection group by night, maybe after 6 p.m. 2 individual psychotherapy sessions. We splitted the patients all over all the residents, so each resident has to know about all the 20 or 30 patients, but he has 2 specific sessions with each one he's responsible on. The family group education. I think we introduced 4 or 5 years ago the NA meeting once every week on Friday. We did a lot of research activities, the addiction psychology oriented research, the addiction screening oriented research, collaborative research with other medical specialties, some researches with other departments in liaison, the collaborative researches with other psychiatric specialties, like the ADHD patients. Dr. Sarah, I was supervising her thesis, and 60% of the sample was having ADHD, adolescent ADHD, and other branches related to psychiatric specialties. The training activities goes to the residents, house officers, psychologists, social workers, the nurses. Everyone is 6 months around training. Between the last 5 years, 12 training courses, for addiction treatment professionals on different topics in etiology, assessment, management, interventional approaches were given. A lot of projects that we were indulged in, mainly it was the Fogarty project since 2012 till 2015, and one under it was training for geriatric addiction. As you remember, the people from Gaza, Dr. Rania, we forgot to write it, training people from Iraqi and Iraq and from Gaza, the UCLA Fogarty project, the ISAM, with the help of Professor Tariq Abdel Jawad, organizing ISAM International Addiction Certificate between 2005 and 2009, the international conference. Until now, this was the biggest conference ever made by the ISAM in 2005. At that time, the elected president of the ISAM was Professor Tariq Abdel Jawad, who is in the National Center of Addiction in Abu Dhabi now. The High Council for Drug Combating Egypt, house officers, training, psychologists, and recovering addicts. We cautiously trying to push the ex-addicts to help us in our treating program. They have pros and cons, of course, and the fear of the relapse. We have many joint activities with the National Council for Childhood and Motherhood Prevention and Anti-Drugs Program among school students. We have also an activities مع صندوق مكافحة وعلاج الإدمان. I don't know if translated to the box of نعم هو ده الهيكل. Next thing, the cooperation activities, the psychiatric department of Sohag University, and it was a breakthrough activity with Sohag, and the syndicate in Sohag called us, and there were problems for transferring 25 doctors from Sohag to here, and Professor Maha created a breakthrough idea that we go to Sohag every weekend for Thursday, Friday, and Saturday to teach there, and it was a nice trip to all of us with a. Yes, they came after to training in the outpatient and the inpatient. We did a training to Mansoura University, to the Tanta University, to Munafaya, all the universities that we gave training activities and collaboration with them. The hotline, drug combating high council, the matrix program and the screening training as well, and the medical student affairs department for anti-drug prevention activities. Thank you very much.
Thank you, Professor Samir. I think, any questions? I think we still have some time for questions. أي أسئلة يا جماعة? I have one question for you. What about the advanced research? You didn't mention anything about your activities and the neuroimaging and.
Yeah, we could spend all day talking about this topic, but as I mentioned, research comes at many levels. So we need all forms. We need social research. We need, but one of the areas that I'm particularly interested in is in the area of biology and in neuroimaging. So if you're interested in some of this, if you Google Enigma, E-N-I-G-M-A, that's the world's largest collaboration of neuroimaging research in psychiatry. I'm very fortunate that I chair one of those divisions, but we have, I think, over 100 countries now that are involved with that. So what we're finding is that looking at the genes, so there's the GARS, the Genetic Addiction Research Screener, that's out there. I can bring that here to Egypt for free. We can work with your university to look at that